And good morning. It is March 10th, 2023. I'm Dr. Ara Digmajian, CEO and founder of the Duke Spine Institute, and we're broadcasting a live surgery this morning. Normally we don't operate on Fridays, but we made an exception this week to take care of some patients who wanted their surgeries done ASAP. Lay still. You're watching the Duke Laser Disc Repair. This is endoscopic spine surgery. And this surgery was developed by many different surgeons, but this particular surgery, the most important part, was developed by yours truly at the Duke Spine Institute over the last 16 years. I could tell you a little bit about the history of the surgery. Like all surgeries, if you look at the history of surgery, it's an evolution of process. And what I mean by that is the surgery wasn't just developed as is on one day. It actually developed over time with modifications of the technique by different surgeons and different doctors as they started to recognize that there was an ability to improve the surgery and do it better. Shot? And so, of course, my contribution to the surgery is to add in what's called the annular debridement with the laser, making it somewhat of a unique procedure, but also very effective at treating back pain. And most of our patients, they do have back pain. Shot? I'm passing the facet joint right now on my way to L4-5. Everyone agrees L4-5 is left, yes, correct? Yes, are we all in agreement?
Yes, sir.
Okay. All right, so this patient has, as you can see, pain in his back coming from two discs, and those two discs are the L4-5, the L5-S1. That's my belief based on my experience of treating this condition for many years, and based on his MRI, which you can see part of that MRI picture there on your screen. Okay, num. Now, he also has pain in his facet joints. Can you show us, Jordan, the facet joints? Can you see this, Henry? The white arrow?
Yes, we can.
So show us the 4-5 facet joint, yeah. And circle the whole facet complex. It's a little back there too, yeah, that. That's 4-5, show us 5-1. Now, I want you to take a look at 5-1, right there, what he's circling. Now, point up at 3-4. A little to the left. There's 3-4. Look at 5-1, look at 3-4. What's the difference? That's not it, that's the pedicle. Go down a little bit, down, 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 right there. Just to the left of that, just slightly, there. That's 3-4, show us 5-1. There's 5-1. 5-1 is darker. We call that sclerosis. What it is it's thickening of the bone. And there's a reason for it. The reason the bones get thick is they're reacting to stress, abnormal stress. Stress that shouldn't be there. We all know that stress can be harmful to your body, right? Whether it's psychological stress or thermal stress or mechanical stress. Stress can be harmful, and that's an example of your body and how the body responds to stress. It thickens bones, it hypertrophies bones, makes them bigger. It thickens muscles, it thickens ligaments, it thickens tendons in an effort to basically stop the abnormal movements that are happening. Okay? Lay still, you're doing great. Shot? Okay, so we are on our second needle at 5-1 on the right. Everyone agree, right 5-1? The trajectory looks good on a lateral view. The problem is the AP view is I'm a little bit too medial. So I need to go a little bit more lateral. All right, in order to get in there. So let's go back to talking about the history of this procedure. That'll be our topic for today. So transforaminal surgery, the idea of going through a hole that's already there in the side of the spine, was really, the person credited with that is Dr. Parvis Camben. I've talked about Dr. Camben in the past. He is an orthopedic surgeon. He's deceased. He died in 2020, I believe. 2020. And he practiced orthopedic surgery in Philadelphia. Where do you feel that?
Where are you feeling that? In your back or your leg? Where are you feeling that? In the back.
Yeah, that's right where the bad facet is. So lay still. So Dr. Camben realized that you don't have to get to the facet joint, or sorry, to the disc by the traditional, what's called translaminar method. I want to be a little bit lower than I was. That's why I didn't like where I was before. I want to go a little bit lower with my needle position. Lay still, Sean. Moving around is not going to help me. I need you to lay still. We're almost done. Sean. Are you okay? This is that painful area of your back we're going to fix. We're just going to that area so we can fix it, okay? I need you to lay still. Where do you feel it? Where does he feel it?
Where are you feeling it, my friend? Back.
Just the back, good. So we're below the nerve root. So Dr. Camben was the first to do surgery transforaminal. Shot? Transforaminal means through the foramen, this way. But his technique was not good. Where is it?
Where are you feeling that? Back? In his back.
His technique was not. Where do you feel it? Back? All right, lay still. All right, stop. Let's get an AP. I can't put numbing medicine here because that's where the nerve is. Yeah. So we don't want to numb the nerve. Sometimes we'll get a little numbing medicine near the nerve and it puts the nerve to sleep for a few hours, and well, patients get very concerned when they wake up and they have some numbness in their foot that they didn't have. It's understandable, absolutely. Yeah. So we prefer not to put numbing medicine down by the nerve roots, which is where we are right now. But that's where the patient's unfortunately experiencing some pain. But this is also the area that we're fixing, so that's why it hurts so much. You okay? Lay still, all right? It's interesting. His back is a lot deeper than I thought it would be. Is that better? All right. We're almost done. His right side is much worse than the left. That's where he gets most of his pain. We're treating his facet joints as well. So Dr. Camben, first pioneer surgeon to go transforaminal like we just did. And then, of course, there's many advances with the technique, the technology, the tubes, the endoscope over the years. Different endoscopes were developed, and some came and went, and then ultimately there's this system we use, which is fantastic. But the point I'm trying to make is no one doctor ever develops a technique by themselves. It's an accumulation of many doctors adding over the years. Many surgeons, engineers working together. All right, so our patient has had, how long have you had back pain for? How many years?
6 weeks bad, but overall total duration 5 years.
5 years. 5 years. So he's had back pain for 5 years. All right, but the last 6 weeks have been horrible. And that's typically what happens. People come to us when they just can't take it anymore. When I asked him, where is your back pain? He told me it's in this area right here. Now, he's actually had surgery before at Laser Spine Institute in Tampa. And he actually did well for many years. But Laser Spine Institute is now out of business. They've been out of business for 3.5 years. So anyway, I looked at his MRI, as you could see, and I said, all right, well, your pain's probably coming from these two discs as well as the facet joints on the side. Is that better? All right.
How you doing, my friend? You all right? Good. He said
So now we're going to test. How bad is that on a scale of 1 to 10? 10. That's L4-5. Is that where you typically get back pain? It's concordant. So L4-5 is a 10 over 10, and that's concordant. Lay still. We're almost done. You can start getting ready to put him to sleep. Okay? We just did what's called a discogram. Did you guys see that? Show them the tear on the discogram. Can you see the tear, Henry, on the x-ray?
Yes, we can.
All right. So you see the black stuff? That shouldn't be there. Okay? It's supposed to be in the middle of the disc, but not in the back there. That tear in the back, right where the arrow is, that's where his back pain's coming from. Okay? At L4-5. Are you comfortable?
Are you comfortable? Yeah.
All right. How bad is that on a scale of 1 to 10 there? Another 10. That's at 5-1. So is that where you typically get back pain? You're going to sleep. When you wake up, all that pain will be gone for the rest of your life. We're going to fix it today. So for those of you watching, what we just did was, I personally, professionally, from all my years, 26 years of doing neurosurgery experience, believe that L4-5, L5-S1 are the cause of his back pain. Okay? I made that basis because of a lot of things. Number one, that's the most common disc to cause back pain, L4-5 and L5-S1. So already, just statistically speaking, I knew that that's probably what was causing his back pain. Number two, he pointed to this area right here. I said, where's your back pain? Point. He pointed right here. That's this area right here. And I said, okay, you're pointing to the L4-5, L5-S1 disc. Then I looked at his MRI, and sure enough, bam, he got 2 bad discs there. So I knew that those discs were the cause of his pain. But he also had pain off to the side here. And what's over here, and when I mashed on that area, it was tender. Those are your facet joints. So we're going to be fixing 2 discs, get rid of his discogenic back pain, and we're going to fix 2 facets today. And you're going to watch the whole thing. The discs are fixed with Duke laser disc repair, shot. The facets are fixed with Duke plasma rhizotomy. What is plasma rhizotomy? It's a procedure we developed here at Duke Spine, pioneered, first in the world to do it. And basically, we're treating the facet pain nerve with a special treatment. The original idea was done with what's called a radiofrequency ablation, or RFA. And the problem with RFA is they don't work or they don't last. And we needed something more powerful. Shot? And we developed that here at Duke Spine. That is power. That power is through basically electrocautery and plasma. The generation of plasma is where you apply enough energy to a solid, it turns it into a gaseous state. So that's what we're doing. We're creating plasma at the tip of this probe, and it destroys the pain nerve to the facet joints. Now, not everybody has facet pain. Only some people have facet pain. Shot? All right, you can see the tip of the dilator is at the herniation right now. We're about to enter into the tear. Thank you, Dr. Berndes. Now, his back is deeper than I thought it would be. Shot? Go ahead.
Yeah.
Yeah. There's the tear. I could feel it go in. Now we're going to put our tube in. Can you see this, Henry?
Yes, we
The
can.
whole surgery is done through this 1/4-inch tube. That's why we only need a 1/4-inch incision. This bleeding is the only bleeding we have for the surgery. It's minimal bleeding. So if you have this kind of surgery done at Duke Spine, you'll have virtually no bleeding and no scar tissue. The only scar tissue we create with the surgery is right here at the skin, a little scar. Everything else below the skin we don't damage. Now, if you were to have a microdiscectomy or a laminectomy, the surgeon's going to destroy your back. He's going to go this way, or he or she will go this way, right in the middle, and they'll hit your bones and ligaments, and they're going to have to take them out in order to get to your disc. Then when they get to the disc, they still won't be able to repair the annular tear and get rid of your back pain. All they're going to do is, at best, unpinch your nerve. Unpinching the nerve releases the leg pain, but not the back pain. Okay, any questions from our audience?
No current questions, just a comment from Pardeep on YouTube. And
Hello, Pardeep.
And they says, hello.
Hello. Now, can you show us what I was talking about, the microdiscectomy laminectomy video? Do you have that one?
Yes, we do.
Let's show them what I'm talking about, how destructive that procedure really is.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back, folks. Luis and I were just talking about bandages. And because these two patients today are Friday, we don't come in on Saturday, we're just talking about, rather than the regular Band-Aid incision we do, we're going to do, of course we still do a Band-Aid incision, but we're not going to put a Band-Aid, because Band-Aids sometimes pull off the steri strips. And I want you to put a larger 4x4 folded in quarter, put it over the steri strips, and then put a big piece of millipore tape. Yeah, and that way they can just, when you put the millipore tape, do a fold at the end so they can grab it and peel it off easy. So it's not stuck down too much to the skin, all right? And then just instruct the family member to pull it off. Then what they can do is they can take a picture and send it to me tomorrow. Just text it to my phone, and then I'll look at it. All right, so for those of you who just watched the video we showed you, that is a microdiscectomy. It is a horrible surgery. I don't recommend it anymore. I've been trained to do them. And just to give you some background on Dr. Duke Majan, the founder and CEO, I trained at the top neurosurgery training program in the world back in '97 to 2004, which was University of Florida in Gainesville. And I was able to train at the top training program because, of course, my credentials, they look at and they select the top 2 students every year. My co-resident was Dr. Paul Tolentino from Harvard, and I came from USC in Los Angeles, powerhouse for neurosurgery. So I was able to choose the top neurosurgery training program because of my credentials, and it was the University of Florida in Gainesville. It's not the best anymore, but it used to be. Things change. Anyway, back then, I was trained by the best spine surgeons to do the best spine surgery available, which was laminectomy, discectomies, and even fusions and artificial discs. So I have a lot of experience doing these surgeries, and I can tell you that they are now outdated and dangerous and totally unnecessary. But still, there's a lot of people getting microdiscectomies, laminectomies, and they shouldn't be, okay, because they harm people. They harm people. So I advocate against those surgeries, yet so many of them are done. Now here's why surgeons do them. They do them because, number one, they make money doing them. Number two, they know that the patient will come back afterwards and get a fusion. They already know that, okay? It's kind of like when you go to a restaurant and you order an appetizer and an entree. You know that while you're eating your appetizer, the entree is coming. Okay? That's what they're doing. They're basically setting the patients up for more surgery in the future because the laminectomy is destructive. It removes the stabilizing structures of your spine. It removes the joints that hold your spine together. So these doctors know that the patient's going to come back and get another surgery. And that's just fine with them because they're part of these practices that make money by basically keep doing procedures for pain. So the patients don't want this stuff done. And yet the doctors are doing it because that's what they were trained to do and that's what they think is the right thing to do for themselves in their practice. But it's not right for the patients. Patients deserve better. The best surgery in the world you can do is the one you're watching right now, the Duke laser disc repair. We don't take any of the bone out. We don't remove the ligament. We don't remove the facet. We don't remove the lamina. We don't remove any bone, any ligament from your spine. You are not going to have an unstable spine when you come out of the surgery. You're going to have a stable spine, and therefore you're not going to need another surgery, and you're not going to need a fusion. You're not going to need pain management because the pain is gone. Now, some patients also have, besides a disc problem, they have a piriformis problem or a sacroiliac joint problem. They have another source of pain other than their disc. This surgery fixes disc pain. Disc pain is 82% of back pain, chronic back pain. 82% of chronic back pain. So if you have other causes of back pain, like your piriformis muscle is torn, or if your facet joints are hurting, this surgery won't fix it. The Duke laser disc repair won't fix that. But we have a second procedure called the Duke plasma rhizotomy that will. All right, beautiful. There's some of that inflammatory tissue, but don't worry about it. That's not as good as some of your other pictures, Henry. We're not going to capture that one. But that's the inflammation we typically see at the back of the disc that's a result of the annular tear interacting with the herniation.
We have a couple of questions.
I will take your questions.
This first one comes from Canes25 on YouTube.
Haynes25. How are you, Haynes25?
And they ask, Doc, I have a C4-5 preneurial cyst in the foramen. Can you tell me about these? Can they cause pain?
Yeah. Thank you, Haynes. 45.
Canes25.
Sorry, 25. I apologize. Perineural cysts, they are nothing. You don't worry about them. You don't treat them. They don't cause any symptoms ever. They're just a structural variation of normal. Perineural cysts never cause symptoms, ever. So leave it alone.
And these next questions come from Roxanne on Facebook.
Hello, Roxanne.
They asked, how many bulging discs can you address in one procedure? And can you do cervical and lumbar issues in the same procedure?
Hi, Roxanne. Thanks for asking. How many bulging discs can I address in one surgery? And can you do cervical and lumbar at the same time, like same procedure? So the answer to the cervical lumbar is no, you cannot do them at the same time. The reason is that the lumbar, the patient is laying on their belly, and with the cervical, they're laying on their back. So it's totally different positioning. We can do them 2 days apart. So let's say you had one of them done on Tuesday, you can have the other done Thursday. And we have quite a few people who travel here for that. And we're able to accommodate the cervical and the lumbar on the same visit and fix it, but we're not able to do it in the same surgery. We are able to do thoracic disc and lumbar disc in the same surgery. We are able to do facet joints, facet joint treatments, and disc treatments in the lower back and thoracic at the same time. But the neck is special. You have to go through the front, and you can't do that at the same time as you're going through the back. And the most number of discs I can treat, in the cervical spine I could treat up to 4. In the lumbar spine I could treat up to 6. And in the thoracic spine I could probably treat up to 4 safely. And what we're limited by is anesthesia time. It's just not safe to have the patient asleep under propofol sedation for longer than, say, 2 hours, 2.5, 3 hours maximum. It's still safe, so to speak, but it's on a case-by-case basis, and you never know how the patient will do. So we like to just cut it off at around 2 hours. If we have to go over 2 hours, sometimes we can, as long as the patient tolerates it, but you don't know if they're going to tolerate it until you start doing that surgery. By the way, you could see the fibers of the annulus. There are about 20 to 25 layers of collagen. You could see them crisscrossing, and then in between them is this stuff here. That's herniated disc. See it coming out right there?
Yes, we do.
Stained blue. So that is what we call the interposed herniation.
We have a few more questions.
I'll take the questions.
This next question comes from...
Well, you know what? Before we do, let's do a video showing people why do herniated disc even cause back pain to begin with. What's the mechanism of that?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
We're done with this L4-5, and I'm going to pull out in just a second, but we're looking from outside the disc right now into the disc. The inside of the disc is down there. You can see the blue stuff, which is the herniation. I've gotten rid of almost all of it. There's just a little bit left. This stuff is not significant, but I'm going to blast it anyway since we're here. But this now, you can see the area that I treated. If I pull back again, right here, all of this, I want you to pay attention. I get this question a lot. So people say to me, well, if you go into the annulus, aren't you creating a hole? We're not creating a hole. The hole was already there to begin with. That's the hole. But check it out. The tube is on the inside about 5.5 millimeters, okay? So you can see as I pull the tube back, the annular fibers close down. And that hole is not even 5.5 millimeters. It's probably 3 millimeters, okay? Actually, you know what? This glass fiber, and this is a good picture, Henry, let me just clear it up for you. Give me a second. This is a good one for our, don't save the whole video, but just save this picture. It's a good picture. All right, you ready? Save it now. Take a couple.
Copy that.
The point I'm making is that if you measure the width of this hole, there's 1 millimeter, 2 millimeters, maybe 2.5 millimeters. That's what we're looking at, okay? 2.5 millimeters of a hole when we're done debriding it, because it actually shrinks down with the laser. The laser shrinks it down, and now it just has to seal a 2.5 millimeter hole. So it's not a 7 millimeter hole. The 7 millimeters was stretching it. It's just a 2.5 millimeter hole. That's really informative. You know what I mean? because everybody thinks the hole is 7 millimeters. We've shrunk it down with the laser. That's one of the things that laser does. It shrinks the tear. It helps repair the tear. Pretty cool, huh? All right. Before we take questions, let's, Henry, add those pictures into our educational folder.
Copy that.
And let's do one more video of how does the Duke laser disc repair actually work. And then we'll take some questions.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
I had no idea. Interesting. Well, I'm getting educated here right now as I'm educating you. I just found out that that when we put some epinephrine under the skin, that it actually has a hemodynamic effect on the heart and vascular system. I thought it just had a local effect. That's incredible. 26 years of a neurosurgery doing surgery, I didn't even know that when you put a little epinephrine under the skin, it actually affects the heart, the blood pressure. I mean, I don't know too many people who would know that. Yeah, but I'm not putting it intramuscular. Yeah, I'm coming over there. I understand that. Intramuscular makes sense. But I had no idea sub-Q, epi, a small amount would ever affect the hemodynamic status of the patient. That's incredible. No, I'm happy not to use the epi either. I really had no idea that it was creating a problem. Huh. All right, anyway. So what we're talking about is before you make an incision, you see the incision I just made?
Yes, we do.
All right, when you cut the skin, there's no blood vessels in the epidermis. There's no blood vessels in the dermis. All the blood vessels are below the dermis, which is the white stuff. And we always, as surgeons, will give some epinephrine in an injection, a little bit, to cause the blood vessels to tighten down so there's no bleeding, specifically the arterioles. So there's no bleeding when you make a cut. And I just found out that, honestly, for the first time, that if that little bit of epinephrine you're giving under the skin actually goes to the heart and blood vessels somehow, and it creates a higher blood pressure, which I'm always fighting higher blood pressure. I don't want higher blood pressure. I want lower blood pressure. All right, Jean. Okay, now we're going to be starting the right L5-S1 because this patient had a herniation to the left at 4.5 and the right at 5.1. That's why I had to do two different sides. It's always best if you look at the MRI and you go to where the herniation is, go to where the herniation is worse, especially if they're having leg symptoms on that side. All right, so now we're just sneaking underneath. Let's take the guide wire out. What happens if you don't take the guide wire out is you'll trap it. What trapping it means is you'll actually, see, it's really fighting to get south there. Trapping the guide wire means that, I'll show you in a second, what happens. You don't want to trap the guide wire, because then you cannot enter the disc properly. Yeah, this is where his pinched nerve is really bad. Shot. You can see the tube is inside the disc. Show us that with the x-ray. There's the tube, the end of the tube right there. So we're trying to get the dilator out. It's cold welded a little bit. Luis is working on that. You know what you can do, Luis? Put the fluid adapter on, and then you can hold down the tube. So let's take some questions, and while we're waiting, we're going to get this dilator out.
Yes, this next question comes from YouTuber named Running Myself Raw on YouTube.
All right.
And they asked, if it is a bulging disc and not herniated, what do you clean up if there's no disc fragments? Does it work on bulging discs?
So thank you so much for asking. I love the question. And I'm going to tell you, a bulging disc is a herniated disc. And I deal with this almost every single day, this misinformation that's out there about bulging disc versus herniated disc versus ruptured disc. The reality is that the truth is that a bulging disc is just a small herniation, but it is a herniation nonetheless. So there is a tear, there is herniated nucleus material within the tear of the wall. Shot. And yeah. And it's just not that what you're seeing with a bulge is there's a lot of disc material inside the tear, but there's not much outside the tear in the back of the disc. That's why it's a bulge rather than an extrusion. But it's not the extruded material that causes the back pain. It's the material inside the tear that causes all the back pain. Shot? All right, so we're trying to get the dilator out, and we're struggling a little bit. Shot? So I'm trying to push. I'm trying to push the material and that's stuck between the dilator and the tube. I'm trying to push it back in, and that should have worked. I just think it's easier from my side, you know, because of the angle. So.
You want to show something about
Yeah. So let me show you what's happening here. We're going to pull the fluoro out. All right, so check this out. So we put the needle in. Let's say this is the annular tear right here. You see this, Henry? Space between my fingers.
Yes, we do.
All right, so we got this guide wire in there inside the disc. We bring the dilator down. Sorry, I need to get it started. By the way, I want to show you, before I do that, why the dilator got stuck inside the tube. You see this disc material right here?
Yes, we do.
It gets stuck between the outside of the dilator and the inside of the tube. Let me see that other tube. Yeah, that, yes. So remember, the dilator, the tube goes over the dilator, right, like this. And there's not supposed to be any space in there, but there is. There's a little tiny gap. And that little gap, if it gets some disc material stuck in there, then we call it cold welding. It actually welds the dilator to the inside of the tube. And they get stuck together and they move together. You can't get them separated because that pressure from that disc stuck in there is wedging them together. Anyway, so that's that. But what I was going to show you is that what trapping the guide wire means. So let me do that real quick. You want to avoid this. There's some disc material in the tip of the dilator too. All right, here we go. Whoop. Here we go. So what I mean is, you've got your guide wire in the disc, there's the tear. You come down, sometimes you want to angle your dilator just further south or further medial, further superior than when your guide wire is, so you get in the tear properly. If you come down and you start going in the disc, you can actually pinch the tip of the dilator against the guide wire, bending it, and then trapping it. Then it's really hard to get the guide wire out. So you want to get the guide wire out before you do that. Okie dokie. Let's take some questions.
Next question comes from Roxanne, once more on Facebook. They ask, if you already have had a few lumbar decompressions, can you avoid the fusion with this procedure?
Yes, you can. Roxanne, yes, you can. This surgery you're watching right now can avoid fusion. It's your only chance, really, of avoiding fusion.
We have a couple more questions.
Yeah, give me a second. I
Yep.
want to show you some of this stuff. So this is the L5-S1 disc herniation and annular tear. I want you to pay close attention. Now, some of this is blood. You see the really dark red specks? Those little patches of really dark red, like right there? That's a little bit of blood, like blood clot. But you see the pink color to the tissue? Like there's a pink color here? That is inflammation. And that's blood vessels and little nerve fibers, and that's what we're here to destroy and remove. That's where the pain comes from. We call it an annular debridement when we remove that and clean up the annular tear. That's unique to this procedure. We're the only place in the world I know doing the Duke laser disc repair, specifically this type of surgery. Now there's lots of doctors that do endoscopic surgery, and there's some that do transforaminal endoscopic, not many. But the Duke laser disc repair with a laser is unique here, and we pioneered this technology. You're not going to find this elsewhere. Go ahead.
Next question comes from Running Myself, once more on YouTube, and they asked, I've been told my ligaments have thickened and are causing the stenosis along with the bulging disc. What do you do about thickened ligaments?
Well, first of all, your thickened ligaments are not the cause of your symptoms. So you don't need to do anything about them. But if we needed to do something about them, we can actually treat them by removing the thickening ligament. I want you to understand something. There is no surgery in the world that makes your discs and your spine look normal. So if you're thinking that there's a surgery that's going to go in there and take out all your thickened ligaments, there's not. The goal of surgery is to remove as much pressure as you can reasonably with the surgery you're doing. And the problem is that of all the surgeries available, the one that does the best job is the one you're watching right now. And we can remove the bulging disc as well as the thickened ligaments that are pressing on the nerves using the laser. So this surgery can do both, whereas a laminectomy cannot. A laminectomy can only remove the bone in the back of the spine, some of the ligaments as well, but not all of them, and hope that your leg symptoms will get better. However, laminectomy has a proven track record of failing miserably, at least 35% of the time. In other words, people don't get any better 35% of the time. With our surgery, people get better 100% of the time.
We have another question.
Yep.
This comes from Canes25, once more on YouTube. And they ask, Doc, what are symptoms of facet joint problems in the cervical?
Great question. Symptoms of facet joint pain in the cervical is neck pain, usually to one side, left or right, could be both. And the key is it gets worse when you turn your head very hard when you turn your head to that side that you're having the pain. So if you're having right-sided neck pain and you rotate your head and look over your right shoulder, you'll feel increasing pain right where you have that facet pain. It'll hurt like hell. And when you touch it and push down right over the facet joint, it'll be sore when you touch it. Really sore down there. So soreness, we call it tenderness of the facet joint. Pain over the facet joint with rotation. Those are the key physical exam features of facet joint pain. Facet joint pain is not diagnosed with anything other than a clinical determination. You have to use a clinical diagnosis. You can also do a diagnostic block. All right, so we're just about done. This disc is more degenerated. There's a lot less of it here for us to treat. Okay. We're done. Oh, just this, you're right. We're going to move on to the facet joint treatment. So for those of you wondering how we treat facets with permanent relief, we do a rhizotomy using a plasma, a wand that allows us to do that. The advantage is that it works better and it lasts longer over a typical radiofrequency ablation, RFA. So we're going to do eventually a randomized study where we'll probably put patients into two groups. One group will be the DPR, the other group will be the RFA.
We have a couple more questions.
I'll take them.
This next one comes from Marcus on YouTube. And they asked, "Hi, my father has lateral stenosis and still has issues post-surgery with pain
4551.
in his legs. Can you say something about the relationship
4551.
between disc and lateral stenosis issues, if there is any? He had some kind of decompression surgery, as I understand
You were
it."
fine where you were. Okay, Marcus, thank you for sharing about your father. I'm sorry that he's still suffering. But yes, we can fix your father's spine here at Duke Spine. That's number one. So let's talk about the relationship. Lateral stenosis is the number one reason why spine surgery fails. It's been documented for 60 years that is the cause of failed back surgery. Okay? That's perfect positioning, by the way, in case you're wondering. Yeah, I'm right on the bone. Go ahead. So lateral stenosis, when you look at an MRI or you look at the spine, there's central stenosis, which is in the middle of the spinal canal, basically in the back of the middle of the disc, and then there's lateral stenosis, which is off to the side. Lateral stenosis includes two types of stenosis: lateral recess stenosis and foraminal stenosis. Lateral recess and foraminal stenosis are most commonly caused by disc herniations or disc bulges, whatever you want to call it. It's the same thing. Shot? Okay, so the number one reason that people have stenosis is lateral recess or foraminal stenosis. The lateral recess specifically is the area of the spine that is medial to the pedicle. And just below the facet joint, which usually enlarges. Shot? That's pretty good positioning. Could be a little more medial, but I'm hitting the facet. So perfect targeting. right on the TP. So to keep going on your discussion, want to be a little more superior. Basically, to completely answer your question, the lateral recess is not accessible through a laminectomy. It is accessible through a microdiscectomy. But microdiscectomy means you're removing the facet to get there. And microdiscectomy is a destructive surgery. It destroys your spine. So what I'm getting at is laminectomy never fixes lateral recess stenosis, ever. No. I'm feeling the facet. Shot. Trying to get the TP. I had it, now I can't find it. Shot. I'm too high. So the Duke laser disc repair, what you're watching us do earlier with the surgery, that is your very best treatment, there it is, for lateral stenosis. Because the lateral stenosis is almost always caused by a herniated disc.
We have another question.
Shot. Give me a second while
Copy
I'm
that.
focusing on this. There we go. Okay, so what it's hard for me to explain just verbally, but I know exactly, I can see it in my head, I deal with it all the time. Laminectomy can fix central stenosis. It does not fix lateral stenosis. Laminectomy is a horrible procedure. We don't even do it anymore at Duke Spine by itself, because to do a true laminectomy, you gotta go wide, remove the facet, remove the ligaments out there laterally, and then you gotta remove the herniation. And to do all that, you're basically going to be doing, so you're using the regular spinal needle? Oh, because he's so deep.
I think it's deep.
Yeah. And so to do that, you're going to have to do a fusion afterwards. Okay, that's what it really comes down to. To properly do decompression of the nerves in lateral recess and foraminal stenosis, you must remove the entire lamina, the entire facet complex. And we do that with a Smith-Peterson osteotomy. I've done 1,000 of them in my career, 1,000 surgeries. And I've done probably 6 per surgery, so I've done 6,000 of those procedures where you're removing the entire posterior facet complex to decompress laterally. But if you do that, you're stuck fusing the patient. So the patient can't have that surgery without having a fusion. Does that make sense? So basically you're committing the patient to do an adequate decompression with traditional laminectomy. You must do a fusion because you're going to have to remove the entire facet complex, and that requires fusion. So that's why we don't do that surgery anymore. We do this surgery instead. This surgery is safer, better. The patients love it. There's no complications. There's no residual stenosis that is symptomatic. There's no back pain because we're fixing the back pain as well as the leg pain. This is the future of all spine surgery right here. The problem is getting these surgeons to switch over to it is almost impossible for a lot of reasons, but one of them is they make a lot of money doing, laminectomy and fusion surgery, a lot more than they do laser endoscopic surgery. This surgery doesn't pay much to the surgeon. So because of that, they don't want to do it. And they don't want to learn it. And they don't want to buy the equipment. The equipment's millions and millions of dollars they would have to spend of their own money to buy this equipment because hospitals won't buy it. Hospitals, yeah. Give me a second. Hospitals won't buy the equipment. So the only way you're going to get this surgery is you come to Duke Spine Institute right now. Because your other surgeons are only going to recommend more invasive surgery that they make a lot more money on. But the patients suffer from. Yes. What's the question?
I was gonna ask about the laminectomy. I was watching videos of it the other day, and I was wondering how is it
why is the tip? Wait, why is this missing?
It was,
Frayed?
yeah.
I'm sorry, why what?
How is it okay that the back of their like spinal cord is like exposed? Like, do they get any weird like do they
No.
get any symptoms from it? Or?
No, they don't actually. Great question though. So somebody asked if when you do the laminectomy, the back of the nerves and everything are exposed. Probably the cervical spine, right? Cervical? Was it a cervical laminectomy or a lumbar?
I guess so. I think it was lumbar.
Hmm. Yeah, no, the nerves need to be decompressed from the back, so they're going to be exposed. That's the problem with the surgery, is that you're removing all that bone just to get the pressure off the back of the nerves. With the laser surgery, we're getting the pressure off the front of the nerves, and if we need to, we can do the back of the nerves. But generally, people only need the front of the nerve decompressed. Shot? 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 Shot, that's the TP right there. Just doesn't even look like it, right? Looks like we're above it. Doesn't it, Jordan? Shot? Shot? I just can't see it that way. It looks like we're on it, maybe. I think we're on it, right? Right there? It looks like we're on it. Yeah, that's the top right there. I agree. I feel it. We're right on the bone. So this is our second rhizotomy burn. And I'm marching my tip along the TP laterally, medially, superior, inferior, just a little bit, just to make sure we get that bad nerve. Because this is a lot of pain for this man, and I want to make sure we get it. All right, what other questions do we have?
Yes, we have another question from Brian Powers on Facebook.
Hi, Brian. Welcome to our live stream of spine surgery at Duke Spine.
And they asked, hi, I was in a bad car accident in '96. I've had 5 lower back surgeries and a neck fusion. My question is, my thoracic area has bone spurred itself together. The pain is brutal on top of all of my other pain. What can you do for that? Thank you.
Yeah, so we need to do an MRI review. I need to see your thoracic. I don't think it's bone spurs. I think it's disc herniation. Bone spurs don't cause back pain, ever. So it's got to be inflammation from a herniated disc or from a facet joint. So I need to see your MRI. I would recommend you use the MRI review link that Henry is going to post right now. And you can actually use that link for an MRI review. It's dukespine.com/VC for virtual consult. You get your MRI loaded, and I will look at it. I'll meet with you on Zoom, and I will show you exactly where your pain's coming from, and I'll tell you what I think needs to be done to fix it. And then you can get it done, and you can be out of pain. All right. That's as medial as I can get, believe it or not. That's it.
Yep.
Go ahead. So we're going to deaden the S1 pain nerve root, right? Not nerve root, but nerve right here. It's called the dorsal ramus of L5. And this is the last one we're going to do. We'll be done in less than 5 minutes. Starting to see a little arterial stuff going on. If we can keep the pressure down.
Sure.
It's a little bit longer. Shot. Right over the facet, that's why. So anyway, for the thoracic patient that was commenting, yeah, bone spurs don't cause back pain. I know doctors will tell you that, but it's not true. Bone spurs can pinch nerves and cause arm pain, leg pain, and even pain radiating around your ribs in the thoracic, but they don't cause thoracic pain. That's caused by disc or facet. Shot? Just need to get a little more lateral. Shot? Shot? When you do this, you want to make sure the tip of your probe's on the bone, and you need to have it on exactly the right spot, or at least as close as you can get it, which is pretty much right where I'm at and a little bit north. If you get it right, the patient's facet pain will literally go away right after surgery. They won't even feel it. And I'm in the right spot. I can feel it. I know the anatomy here. I've been there hundreds of times. During my spine surgeries, when I do them open, when I did lumbar fusions at 5-1, I was here not even hundreds, probably thousands of times. And I know this anatomy quite well, so I can see it in my mind's eye. As I do this, I'm visualizing the facet and making sure I'm getting that little nerve. Good job, everybody. All right, remember, big bandages so that the patient can peel them off. All right, I'll take more questions from the audience. Again, just to recapitulate, this patient has had debilitating chronic back pain for years. It's gotten worse in the last 6 months. He can't do anything. I got an MRI, looked at his discs. He had 2 bad discs causing his back pain, and the MRI will not tell you that. I have to figure that out. I get all these people asking me, will you look at my MRI report and tell me what I need done? I can't do that. Nobody can do that. I can lie to you and look at your MRI report and tell you what you need done, and it'll be wrong. So if you want to know what you really need done, you have to do a consultation. And when I do the consultation, I literally have you stand up and show me where the pain is. That's the way you have to do it. So if you want an accurate diagnosis about what's causing your back pain, neck pain, thoracic pain, you must do a virtual consultation at Duke Spine. We will diagnose it. I'll need to see your full MRI images before that, basically at the time, but you're supposed to send them in before that, and your report. So if I have those 3 things, you on camera, your MRI report, and your MRI images, I can tell you where your pain's coming from, okay? About 98% accuracy. And then, of course, we can treat it for you and get rid of it. Let's take questions. Just go ahead and put the link up so people can see it and click on it. Remember, Duke Spine also has an app. It's free. You can download it. It's got good information, teach you a lot in there. And I'll be talking to you in just a couple of minutes. Let's go ahead and run a video. Again, let's run the video of the microdiscectomy so they can see how damaging the microdiscectomy is.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
And I'm Dr. R. Dukemajian here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on, and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work, with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming, because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
And good morning, I'm Dr. Dukemajian. I'm here with one of my lovely patients from Canada, who's visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years. Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair endoscopic surgery. And you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but you know, horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L5-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was, you said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L5-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm going to be, after this, this year, I hope to be the strongest I've ever been, and I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport, and that's end goal, and I feel like it's a possibility now.
Absolutely.
To do it.
You can.
Yeah.
We're rooting for you.
Mm-hmm.
And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's very hopeful, and if you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports in the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right. Congratulations.
Thank you.
All right. Take care. All right, I'm here with one of my patients who traveled from Australia to Florida to the Duke Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is
and
gone.
my leg pain is gone
Awesome.
from the disc. Yeah.
From the surgery yesterday.
Surgery yesterday. Yeah.
And you had the Duke laser disc repair.
I had the Duke laser disc repair. Yeah, that's right. Yeah.
So why did you come all the way to Florida from Australia for the Duke laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Duke. I found Dr. Duke, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L5-S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain about with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma. There's no scar tissue. There's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, you said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and their loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing towards others as well. And it's not really, about you. It's also about your people living around you. That's very important. Yeah.
You came here for a purpose. You got your surgery that you had hoped to do. Now you're going to go back to Australia.
Yeah.
You got a long trip ahead of you coming up. And how do you feel about your experience here at Duke Spine overall?
Oh, it's really good. Staff is really welcoming, and it's spot on, and they receive you with a smile, and which is really great. And my father was telling, it's amazing how he never thought that in American health system, people the clinicians are like this. So he was treated differently probably before while he lived in US, but it was really amazing, and your staff is really cool.
Thank you.
Yeah, they're welcoming. They're good.
Thank you very much.
And you are the best. I
appreciate it. It's an honor to take care of you, and it makes me feel so satisfied to see you happy and out of that pain. So congratulations.
Thank you, doctor.
You're welcome.
Yeah. If you're suffering from back pain, this is a very good cutting-edge technology and very advanced surgery, which Dr. Duke has developed his own, and without minimal, no damage to the bone, no damage to other things, and easily approaching to the disc and removing it. He is very skillful in reaching there without, manipulating any of your muscles or anything. And you can see from me that I have recovered within few hours after the surgery. So I would say if you don't want a long-term complications from the surgery, this is the best surgery you can get done by Dr. Duke here.
Congratulations once again.
Thank you, doctor.
I'm Dr. Duke Majan, and you are just watching me operate in the operating room at Duke Spine Institute. And I'm going to just tell you the surgery for this patient went very well. We didn't have any complications or problems. He had 2 herniated discs, 2 bulging discs, that were pushing on the nerves going into his legs, but also causing back pain. Those are two completely separate issues, and it's important that people understand that. Nerve symptoms come from two things. The nerve we're talking about is called the nerve root, and the nerve roots come out of this hole. They travel all the way down to your toe in your leg, and if you get pressure on the nerve root right here at the back of the disc with a herniation, that's going to compress the nerve root, squeeze it, cause damage to it. Patients will experience weakness in their leg, numbness in their leg, and even tingling if it's really bad. But there's a second phenomenon involving the nerve roots called inflammation or radiculitis. Radiculitis is inflammation of the nerve root. And what's happening is the inflammation that's happening in the back of the disc where the herniation is, it's spreading onto the nerve root just behind there. And it's causing irritation of the nerve root. And that irritation is perceived as sciatic pain, pain in the leg. So the pain in the leg comes from inflammation in the back of the disc, which is what we're targeting today to fix, getting onto the nerve root causing leg symptoms. And then the weakness, numbness, and tingling comes from pressure on the nerve root, not inflammation, but pressure. And finally, you have back pain, which comes from a tear in the back of the disc. Now, we were asked a question earlier. I have a bulging disc. I don't have a herniated disc. Bulging discs are herniated discs. They're all the same. A bulging disc is just a smaller herniation. And what I mean by smaller is, okay, so for example, the best thing to think about with a herniation is like a mushroom, okay? There's two parts to the mushroom. There's the stalk and there's the cap. Think of the cap as what radiologists typically call a herniation. If you have a herniated disc with a cap, it's called a herniation. If you have a herniated disc with just the stalk, which is the part of the mushroom inside the tear, they call that a bulge. But it's still a mushroom, all right? If the mushroom has a small dome, it's still a mushroom, all right? So if some mushrooms have a big, thick stalk and a small dome, they're still mushrooms. So the geometric properties of the herniation, they're different for everybody. No two herniations are the same. Small herniations are thick stalk, small cap. Those are called bulges. Big herniations with the big cap are called herniations, but there's other names like protruded disc, ruptured disc, extruded disc, slip disc. Those are all the same thing. It's a herniated disc, and that's just the simplest way to call it. All right, so we went in and got right into the herniations, and I removed them with the laser. Everything went very well. L5-S1 was particularly tight. There wasn't a lot of room in the foramen because of the amount of narrowing and herniation and collapse of the disc, enlargement of the facet joint, scar tissue. But that was the one we did last. It went well. And then we did the rhizotomy at the end, and that went well as well. The rhizotomy is done to treat facet joint pain. Unlike the disc pain, which comes from a herniated disc, the facet joint pain comes from the actual facet joint itself. And that's this structure right here. Can you guys see that? Right here, the facet joint right there. So what we did is we burned the pain nerve to this facet joint. There's one nerve here and there's one nerve here. You have to burn the one above and below in order to denervate, get rid of the pain at the facet joint. All right, questions?
Questions. This only got one. This comes from Canes25 on YouTube. And they said, Doc, speaking of bone spurs, this is when we were talking about that earlier, I'm trying to make some difficult decisions, having severe bone spur formation at C3 through 4, right side, slight side cord compression at root with foraminal stenosis. What would be classic symptoms of this? I live across country, but may end up seeing you. My local surgeon says if I want, he can take this bone spur out and do a microforaminotomy if I want, but won't promise me any outcome for symptoms.
Yeah, well, first of all, no surgeon is ever going to promise you an outcome of surgery. But Duke Spine Institute offers a guarantee. That means no matter what the outcome is, which we can't predict, we're going to take care of the problem if you still have a problem. I'll give you an example. The most common cause of back pain after Duke laser disc repair is the facet joints. So a lot of our patients, probably 10 to 15%, are going to have pain in their facet joints that is aggravated or surfaces because after they have the laser surgery on the disc, they have facet pain. We still have to treat that, otherwise it won't go away. So if you have the guarantee from Duke Spine, we're going to treat that or whatever other cause of pain you have. We're going to treat it, no cost to you, the patient. You have to have the guarantee though. And our guarantee requires you pay the full fee for the surgery. Most people are getting a discounted fee. So if you want the guarantee, you pay the full fee, which is the full charge, and then you're going to get 2 years of, we'll take care of any issues you have after the surgery. So that's a guarantee. No other surgeon is going to offer you that guarantee. It's not available anywhere. I know what every other spine surgeon is doing, and nobody offers that guarantee. Okay, we do. We're the first ones. We've been offering it for over 10 years now. And there are people who take it, and they pay the full fee. And if they have a problem, they come in and we take care of it right away. So as far as guaranteed outcomes, don't expect anybody to do that. A microframenotomy is a complete bullshit procedure. There's no such thing as a microframenotomy. I could call it a warp 6 foraminotomy to make you impressed. I could call it a Shanunigan Mazipakak foraminotomy, and then you're going to go, oh, that sounds so cool, I want it. In the end, they're drilling the bone away from your spine and they're taking your facet joint out. That's like removing one of your legs and saying, hey, how do you feel today? Oh, my foot's hurting. What should I do? Oh, let me do a micro-kneectomy. All right, what are you going to do? I'm going to take you from your knee down, gone. But it's a micro-kneectomy. So what is the micro part? Nothing. It's just great advertising. So what are you doing? I'm going to cut your leg off from below your knee so your foot doesn't hurt anymore. It's stupid. Stop believing the stupidity. Okay? The Duke laser disc repair fixes pain from disc osteophyte complexes. That is the least invasive, best surgery in the world. There's nothing better. You can sit there and mentally masturbate about, well, how much of the bone spur are you going to get? Are you going to get all? You don't need your bone spur gone. The bone spur isn't the problem. Your bone spur will become a problem when you're 243 years old. So good luck living to 243. I've said it over and over again. Bone spurs don't cause symptoms. It is absolutely true. It is extremely rare that a bone spur causes symptoms. And any bone spurs I need to remove, I can remove when I take the herniation out. So your very best surgery is the Duke laser disc repair. But don't believe me, go out and find out for yourself just how miserable you'll be afterwards. Because even if your surgeon does a microframenotomy and removes some of the bone spur, when you get an MRI later, you will still see those bone spurs, I guarantee it. And you will still have problems. And then you're going to be in so much pain, guess what your surgeon's going to say? Now you need an ACDF. Basically, he's just milking you for procedures. You need an ACDF today or the Duke laser disc repair. That's the decision you have to make, not a bunch of procedures that aren't going to work but sound good and are quote-unquote minimally invasive, and then an ACDF in the end, because that's where you're going to end up. You understand what I'm saying? I hope I made that perfectly clear. People spend way too much time fooling around with information that's useless, meaningless, and doesn't have any benefit to them. If you want to know something, ask me. I offer you a virtual consultation. Take it. Okay? That's the only way you're going to get me to look at your MRI and look at your report and tell you my recommendation. What I recommend is literally the very best you can get. How do I know that? Because every other spine surgeon in the world does whatever surgery they do. I've done it. I've done it hundreds of times, and I do it better than they do. I know it's hard to believe that. I know it sounds arrogant. It's just a fact. Watch my fusions. You'll see them. They're online. Watch my discectomies. Watch my laminectomies. Watch my whatever. It's all there. I've been publishing it for years. Those surgeries suck for many reasons I'm not going to go into. If you want personal attention from me, become my patient. That's the best advice I can give you. If you won't become my patient, that's fine, no big deal. But then at least do the virtual consultation so you can get personalized information. The only thing I can say, generally speaking, is that microframenectomies don't work. And if they do, you'll be back again within 6 months to 2 years, somewhere in there, getting a fusion done, because it's going to create instability. All right, next question.
No current questions. Just a comment from Canes25 saying that was my problem. I can't differentiate whether it was facet or another. I need, sounds like I need to see you. Oh, no, I need to see you, sounds like. Thanks for giving it to me straight. No, it's not hard to believe my neurosurgeon is the guy I want to be most confident. That's what it is.
And I appreciate that. My confidence, by the way, for those of you wondering, it's not delusionary. It's not like I'm dropping acid and I'm confident. It is because I've fixed so many people, thousands and thousands and thousands of people over the years. I know exactly how to fix people. And yes, I can fix you with a fusion. Absolutely. The real question, though, is why? I could fix your foot pain by cutting your leg off. But why? Let's go fix the source of the pain in your foot. You know, let's not cut the leg off. There's a lot of problems that come from cutting the leg off. A lot of disability that comes from that. You get disability from fusions. When you start fusing the joints that are meant to move around in your neck so you can turn your head, you start fusing those joints, then you're going to have more problems. That's the whole point. We can get rid of your foot by cutting your leg off, but you're going to have problems. You're going to have a prosthetic put on. The prosthetic is never going to fit perfectly. You can't go running anymore. You can't do water sports really anymore. Of course, there are prosthetics that allow you to do stuff, but you're never going to functionally be the same. So I'm trying to help you avoid making a bad decision and having a surgery that may give you temporary relief but create new problems for you that you didn't have before, or even temporary relief that requires more treatment in the future. Duke Spine's philosophy is fix it permanently and fix it in the least intrusive way possible. I can't tell if your pain is coming from your facet just talking to you, or your disc, but I can guarantee you it's not coming from that bone spur. And I could go and operate on you today, get rid of 100% of your pain for the rest of your life, and that bone spur will still be there. All right.
And that is it.
I hope you enjoyed the broadcast. It's always entertaining talking to you folks. And we'll be back again for another Duke laser disc repair in about 30 minutes.